Hello, everyone. My name is Jacob Esarco, and I'm a second-year medical student at Ohio University's Heritage College of Osteopathic Medicine. The purpose of my team's project was to investigate and quantify the potential intraoperative forces applied to an orthopedic surgeon during acetabular reaming. Increased physician-reported procedural-related injuries have emerged as a critical issue facing surgical teams and healthcare. These issues include radiation and smoke exposure, infection, overuse, and injury to the musculoskeletal system. Many studies presented at the 2021 ACUS Symposium aimed to quantify the prevalence of occupational-related hazards exposed to orthopedic surgeons. One study surveyed 63 female surgeons, asking if they've ever sustained an injury due to their occupation. The study revealed that 68% admitted to some type of musculoskeletal injury, with the most prevalent being of the upper extremity. Similar studies show comparable results, with one study of 183 arthroplasty surgeons found that 66 reported musculoskeletal injuries. 31% of them then went on to require surgery to then return to work. The largest study within our analysis surveyed 586 surgeons, and it found that 96% of them reported experiencing musculoskeletal pain resulting from their work. A little additional data from this study, nearly 50% of the pain was reported to last longer than 30 days, and 33% of all the pain was rated at least 5 out of 10 or greater in intensity. Some literature has even gone to see how much energy is expended in a total hip or knee arthroplasty. These operations can be incredibly strenuous, forcing surgeons to complete highly intensive and repetitive tasks or to have them hold ergonomically unfavorable positions for long periods of time. Energy expenditure during arthroplasties has been estimated to be at a rate of about 340 calories per hour for a total hip or 320 calories per hour for a total knee. To put this into perspective, a 150-pound person on a bicycle at 5.5 miles an hour on a flat surface expends about 300 calories per hour. Surgeons are exposed to grueling environments, and when surgical teams were asked how they combat some of these ergonomically challenging environments, many responded that they have no such intervention and simply choose to ignore it. We saw the opportunity to add to the literature and quantify proposed strain placed on surgeons in the operating room. We tested new and used acetabular reamers using a computer-controlled MTS Bionix tabletop test system. Each reamer was lowered at a rate of 30 millimeters per minute onto machinable wax blocks. The depth of the reaming was then standardized to 1/2 of the diameter of whatever specific size reamer was being used, and the computerized construct then measured the axial force and torque applied through the reaming fixture during each trial. On the right, you can see a picture of our reaming construct, which utilizes a striker motor and a reaming shaft provided by Next Step Orthopedics, and it would then lower onto that blue machinable wax block, and then we could simply replace a new block and a new reamer for each trial. 4 different size reamers were used: 48, 50, 52, 54 millimeters for both the new and used. The used reamers were of a hemispherical style, while the new reamers were low profile. Statistical analysis of each individual trial was resulted in a statistically significant increase in axial force for all used reamers when compared to their same size new counterparts. Interestingly enough, there was not a significant difference in axial force when comparing only the new reamers to each other. When looking at the torque, all but 2 individual trials resulted in a significant increase in torque when comparing the used versus new reamers. Overall, then, when averaging all the trials together, there was a markedly increased force when comparing new and used reamers. And to put some of the axial forces also into perspective, every extra 100 newtons feels like about 22.5 pounds on the construct. What we made of our results was that poor equipment quality was correlated with more forces being applied to the reaming construct. And this may add increased wear and tear to a surgeon's musculoskeletal system within the OR. And understanding the optimal lifespan of reamers could prove critical in reducing forces and help take the toll off of surgeons. Finally, moving forward, as AI becomes ever more prevalent, preoperative AI planning can allow for more precise reaming and decrease the need for a repeated ream. I would just like to thank Dr. Mark Gittens and his PA, Sarah McNeil, for assisting with the project and providing a memorable summer research experience. I would also like to thank Next Step, OrthoNeuro, the Orthopedic Foundation, and Ohio University for this opportunity. Thank you.